We have a few attendees that are going to continue to join, but I want to make sure that we start on time so that we can allow our presenter to have his full time, and then that we can end on time for you all as well. So before we get ourselves started, I wanted to just provide a bit of housekeeping. Please note, as an attendee, you are muted. So should you need to communicate with me if you're having any trouble, fingers crossed Zoom no longer has any trouble like it did yesterday. But if so, you can let me know by using the chat box as well as the Q&A feature if you need to. Now, given our remote delivery, it is important that we are all respectful and patient with each other as we get into Tuesday's norm. But I would like for you all to feel comfortable by asking questions. And again, you can do so by using the chat feature as well as the Q&A feature. So we are recording, and I will post the seminar on the Swetland Center's website by weekend, along with any resources that are to accompany the presentation. Now, I know that we have started class at Case Western Reserve University, and some of us have been able to see our friends and our peers in person, but many of us are still missing each other while we work from home. So if you can please say hello by using the chat tool, let us know who you are and what organization you are from. And please make sure that you are sending your response in the chat box to both panelists and attendees. All right, so of course, good morning, my Swetland family. Good morning, Ruth. All right, good morning, Alicia. Good morning, Paula. Okay. All right, and I know that we do have some Wholesome Wave people in here as well, so welcome to our seminar. Thank you for joining us today. So as we move along, definitely continue to say your good mornings to everyone using the chat feature. I will post a link in a little bit that can be used to record your attendance. So just by clicking the link, you'll just put in today's date, your name, and I believe your email address, so that we can just know that you were here and that we can keep you in the loop for upcoming seminars. All right, so now to today's presenter and presentation. We will be hearing from Dr. Tim Ciesielski, who is a Senior Research Associate within the Swetland Center. He has used a variety of epidemiologic approaches to study perinatal, neurocognitive, and chronic health problems. Adverse outcomes in these areas have massive public health consequences, and the long-term goal is really to address the modifiable causal factors within the context defined by non-modifiable factors. He notes that this work requires the coordination of information from many sources and has led to efforts in transdisciplinary communication, diverse evidence integration, and planetary health. At the Marianne Swetland Center for Environmental Health, he has been involved in several projects, including the Modeling the Future of Food in Your Neighborhood study, or Foodnest 2.0, the Building Capacity for Obesity Prevention Study, or BCOP. So you can see that we really like our acronyms in the Swetland Center. But he has also been helping on other rising projects that are aiming to better understand community-level environmental health disparities. Today, he will present on his work with the Foodnest 2.0 project on factors that are associated with elevated dietary inflammation among SNAP utilizers in a low-income urban setting. So now I'm going to switch off my slides so that Tim can get us started with today's presentation. Okay, Tim.
Okay. It's telling me now who can share. It was working. Okay. All right. Hi, everybody. Thank you, Jennifer. And thank you to everybody for coming today and being willing to listen to me chat for a little bit about some of the work we've been doing since I arrived at the Swetland Center 6 months ago. So basically, just to get everything started today, we'll be talking a little bit about elevated dietary inflammation among SNAP recipients. And in particular, we're going to focus on nutritional disparities and disease. So just to give everybody a little bit of background, the team that put this project together was basically a group of folks from the Marianne Swetland Center for Environmental Health and the Department of Population and Quantitative Health Sciences. A pretty diverse team. First, obviously, there's me, Tim Ciesielski. I did the mixed model analyses, the cross-sectional analyses, and drafted the manuscript, which we are hopefully going to be submitting very soon. There's David, I'm going to mess up his name, Nagenda Himana, close, hopefully, who did the marginal structural models, longitudinal analyses, and helped me draft. Abigail Roche has nutritional expertise, and she's also a student in PQHS. And she's helped us with a ton of things, including recognizing where these dietary intakes stand in terms of how close they are to meeting dietary reference intake standards. Scott Williams is one of my mentors. He was my postdoc mentor, and he's trained in genetics and does a lot of integrative transdisciplinary work. And of course, there's Darcy. Darcy Friedman runs the Marianne Swetland Center and obviously has collected this food NACE data that I'm going to be talking to you about today. And we've also had other help, just so people are aware. Millie and Alicia have helped us collect a lot of this food nest data, and many other people that I can't actually go through them all today. But this data wouldn't be in the state it's in without lots of people helping. Okay, so just as a brief outline, we're going to go through some background on poverty, diet, and disease. Then I'm going to talk about some methods. What is it that we did? And then I'm going to talk briefly about the results. What specifically did we find? And then a fair bit of discussion. What do these patterns mean? And can we design interventions? Okay, so this is the important background. Many low-income Americans really need assistance to obtain food. In January of 2020, there were 37 million people that were receiving SNAP benefits. That's over 11% of the US population. And clearly the pandemic is increasing this need. I just saw some figures of Cleveland produced by a Swetland team member that showed in 2020 this need for SNAP benefits and need for food assistance has expanded beyond the areas of the city where it was chronically needed. So overall, SNAP is designed to help people avoid hunger. It's designed to stop food insecurity. It's really not designed to help people eat healthy. or avoid disease. So in general, that's obviously a good thing. Food security is good, but it's not nutrition equity. So SNAP has done some good things. Receiving SNAP is associated with better pregnancy outcomes, long-term child development outcomes, ultimate success as adults. It's lowered criminal recidivism rates, which kind of makes sense. If you can get food when you get out of prison, you're less likely to commit the crimes that will put you back. However, it's not all positive at this point. Receiving SNAP is also associated with worse overall diet, as measured by the Healthy Eating Index, which we will talk a little bit more about in the next few slides. And it's also associated with worse cardiometabolic mortality. In other words, more deaths from things like heart disease, stroke, diabetes. So, looking at this big picture, the total effect of SNAP on health is hard to estimate. But overall, if we could keep the good and reduce the bad and possibly improve the program, we might be in good shape. So how could we actually achieve nutrition equity for SNAP recipients? What might actually help the program? So this has been looked at, as I mentioned, with the Healthy Eating Index. And I'm sure some of you are familiar with this metric. It basically reflects broad categories, things like fruit and vegetable intake. And it gives you a really good general sense of the quality of someone's diet. However, it's not physiologically based, and it doesn't specify exactly what nutrients or dietary components are missing. It gives you big categories. So the Dietary Inflammatory Index is a metric that could help us address these issues with the Healthy Eating Index. So, how could we take a closer look at this? So in Darcy's Food Nest data, comprehensive 24-hour dietary recalls were taken. Specifically, people were asked what foods were eaten. And this type of data is pretty high quality, doesn't require a long period of time that you have to remember. It's just the last 24 hours. This is pretty much the best dietary data you can get. And then we were lucky enough to take that data and run it through the nutrition data system for research, which is out of the University of Minnesota. And it's basically a computer program that allows you to figure out exactly what nutrients were in those foods that the people reported eating. And then from that data, we can calculate a dietary inflammatory index, which is basically a quantitative estimate of how much chronic inflammation that these nutrients would cause. So basically, high DII scores are associated with increased risk of inflammatory diseases, things like cardiovascular disease or cancers, diabetes. So just a little bit more about the Dietary Inflammatory Index, because it's a bit of an interesting metric and it's not something that everyone is familiar with. So essentially, as I was mentioning before, it attempts to link physiology and diet and give you an estimate of the internal inflammation that's caused by what people are eating. So effectively, how much does diet raise inflammatory mediators? Now, I don't imagine everybody is well versed in inflammatory mediators, but this includes things like interleukins, IL-1 beta, IL-4, IL-6, IL-10, TNF-alpha, and C-reactive protein levels. You may not know it, any or all or any of these, but increasing levels of most of these are associated with inflammation. So probably the one you may have heard of that's most commonly talked about is C-reactive protein. But in brief, just without getting into the nitty-gritty, to calculate a DII score, you basically take the amount of the food item that the person ate and you multiply it by a literature-based coefficient. So this coefficient is based on researchers reading the literature and looking at the relative ability of that food item, that dietary component, to raise these mediators I just mentioned. So you do this for multiple food items, then you sum the answers, and you have an estimate of how much net inflammation that diet will produce. Okay, so here in Darcy's food nest data, we're able to use the NDSR and DII in a low-income urban population. And we were able to use it to assess if SNAP recipients have more inflammatory diets or if specific nutrient deficiencies might be driving these differences. We're also able to look at other factors that are associated with highly inflammatory diets. The overall goal of our approach was to describe the diet of SNAP recipients over the 3 years of the study and identify deficiencies that can be addressed with interventions, things such as incentives. And if interventions of this type can lower DII scores, they might possibly lower inflammatory disease risk in this population. It's a pretty straightforward approach. So just a little bit more about the data we're using for this study. The Future of Food in Your Neighborhood study, Food Nest 1.0, for those of you that are interested, there is a 2.0. Effectively, we evaluated the diet of 409 participants annually for 3 years. They were from Columbus and Cleveland, and I'm going to show a little bit more about that in a second. And so that's the first part, the evaluated diet. The second part is the food stores in the neighborhoods were also studied annually for 3 years to determine the quality of the food that was available in the neighborhood. And you can see here from the study inclusion flow chart that you had to participate, you had to have at least 2 dietary recalls within a 37-day window during at least 2 of the 3 years of the study to be included in the analytic data set. Okay, so without getting bogged down too much into the methods, we basically took 3 approaches with this data. First, we did a cross-sectional analysis. And basically in this process, we used multivariable adjusted mixed models to estimate the association between current SNAP status and DII score. Then we looked to see for if there were nutrients that might be driving these differences in DII. So are there nutrient intakes that differ between SNAP recipients and non-recipients? And for that, we used non-parametric Wilcoxon Mann-Whitney test to determine if the food items that were differing consistently by SNAP status in each of the 3 years of the study. And then finally, we did a longitudinal analysis that, as I mentioned, David ran, that is essentially allowed us to sort of strengthen our findings by assessing if time varying of confounding could explain our findings. And to do this, we used marginal structural models to test to see if we still saw the same associations that we saw in the cross-sectional analyses. Okay, so the study population, as I mentioned, 409 residents of these 2 neighborhoods. The neighborhood in Cleveland, you can see there in the upper map, is St. Clair Superior, 217 participants from there, and then Columbus, it was the South Side neighborhood, and 192 participants came from that neighborhood. Just as a brief overview of our study population without getting too into the nitty-gritty, it was mostly female. So 76% of the participants were female, 67% of the participants were Black. I think this is the most important thing to note. 83% had annual incomes less than $30,000. So as I mentioned before, these are low-income urban neighborhoods. The median age was 53, and We had 204 people that were consistent SNAP recipients, meaning they received SNAP in each of the 3 years. 99 that were occasional SNAP recipients, meaning, less than 3 but more than 0 years, and 106 that were non-recipients throughout the study. So just to get right into the results right off, the cross-sectional associations. These are from the multivariable adjusted mixed effect model. Basically, what we found, and I'm going to get into the details in the next slide, is we did find that receiving SNAP was significantly associated with higher or worse DII scores, meaning more inflammation, and several variables were significantly associated with lower or better DII scores. And these included older age, higher education level, making a conscious effort to eat healthy, and also white race. And so for those of you that like numbers, here's some details of the results from our multivariable mixed effect model. As you can see, just if you're curious about the methodology, we used a random intercept for each participant to account for clustering the data set. That way we could combine all the data into one data set. So there were 3 values per person, 1 for each year, and the clustering was controlled by the random intercept. So as you can see, current SNAP use with this beta we have at the top here, the beta is estimating the change in DII associated with receiving SNAP. So increases in DII indicate more internal inflammation, and as you can see, we have current SNAP use was associated with a significant increase in DII of 0.4. Now I should probably have put up a just the range of DII on the slide, but it's ranging from -2 to 2. And then you can see also other things on, covariates. I won't get too much into the details, but these are the things I mentioned before: age, white race, education level, and making a conscious effort to eat well. Okay, so we see this pattern. Current SNAP use associated with worse DII. All right, well, are there specific nutrients that might be driving this pattern? So when we looked at all 3 years of the data separately, 4 parameters were consistently and significantly lower among the SNAP recipients. That's total dietary fiber, beta-carotene, magnesium, and vitamin E. And so 3 of these had a dietary reference intake to compare to, and all 3 of those were well below the recipients and non-recipients in these neighborhoods were well below the dietary reference intakes. So total dietary fiber, magnesium, vitamin E, and even though there was no difference in vitamin D between SNAP recipients and non-recipients, both recipients and non-recipients were well below the dietary reference intake. Okay, so longitudinal analyses. These are the marginal structural models. Basically, what we found in these marginal structural models corroborated what we found in the cross-sectional models. So we saw a significantly increased DII score and a significantly decreased intake of 4 anti-inflammatory food parameters amongst SNAP recipients. And so here you can see the percent decrease in intake associated with receiving SNAP, 19% for dietary fiber, 38% for beta-carotene, 12% for magnesium, and it's off my screen so I can't see it, but I think it's 20 for vitamin E. So what does this mean? There's a lot here, but I'm going to sum it up in this one slide. Basically, SNAP recipients have higher DII scores, and this, again, is a metric associated with increased risk of inflammatory diseases, chronic diseases. We have 4 anti-inflammatory parameters that are consistently lower in SNAP recipients: fiber, beta-carotene, magnesium, and vitamin E. and 4 anti-inflammatory parameters that are well below their dietary reference intakes for all recipients, whether you're getting SNAP or not. And that's the fiber, magnesium, vitamin E, and vitamin D. So other things that are modifiable that we might want to mention, if you recall from looking at the full model, increasing education level and a fresh and healthy diet also were associated with lower or a better DII. Okay, so overall, what we saw in the cross-sectional and longitudinal analyses corroborated each other. These were similar findings, and we found no evidence that these patterns could be driven by time-varying confounding or our initial modeling assumptions. So that's a good thing. We have convergent evidence from the cross-sectional and the longitudinal. We do have some weaknesses. We didn't really have specific data on how much SNAP money participants were receiving. We also had females overrepresented in the data. This is a consideration more for generalization. And in terms of strengths, this is the first study to assess SNAP with a physiologically based metric. Again, I mentioned the convergence of evidence from the 2 types of models. And then the other thing is that we've identified specific modifiable nutrients to target. These are things that can be changed. All right, so just to dive a little bit deeper into each of the findings and discuss them in terms of their implications. SNAP recipients have higher DII scores. Okay, so they're eating diets that produce more inflammation, thus increasing the risk of inflammation-related non-communicable diseases. These include things that have been linked to DII in the past. Elevated DIIs have been associated with cardiovascular disease, colorectal cancer, prostate cancer, neurocognitive decline, and depression. So moving from there, can we say something more specific about the inflammation in these low-income urban neighborhoods? Well, the diet-driven inflammation in these neighborhoods appears to be driven primarily by 5 anti-inflammatory nutrient deficits. And we kind of went through those already. Fiber, beta-carotene, magnesium, and vitamin E. And these specific deficits have inflammatory and immune implications above and beyond what's known about DII. And I think we'll walk through that just quickly here because we're doing okay on time. So dietary fiber. Okay, so what I have in these charts here, basically I have a dietary reference intake, age 31 to 50, and where males and females differ, I also put in a sex-specific dietary reference intake. Then I have the median and interquartile ranges for SNAP recipients and non-recipients in our study, and then a US intake estimate when I was able to find one. So basically, as you can see, the adequate intake for females is 25 grams per day, and for males is 38. But neither our SNAP recipients nor non-recipients came really even close to that. And of course, as I already noted, the SNAP recipients are significantly lower than the non-recipients. And as you can see, the non-recipients are about where you'd expect for typical US diet. So this all makes sense. If we start to think about the specific inflammation and immune implications of low dietary fiber, well, high dietary fiber is known to lower the risk of cardiovascular disease. It's perhaps helpful with GI function and weight control and various other parameters that where the evidence is less certain, like glycemic control. So that's the inflammatory piece. The immune piece is that high fiber intake is also linked to better immune responses to respiratory viral infections. So this basically, fiber's been associated with increases in the number of repair macrophages, and it's also been noted to limit excessive neutrophil recruitment to the lungs. In terms of beta carotene, so again, I'm not a registered dietitian, but I'm well aware that it's a key precursor to vitamin A and retinoic acid. So as you can see, there's no dietary reference intake for beta carotene. But in our SNAP recipients obviously had much lower median than our non-recipients. And there wasn't a definitive US intake estimate that I found. I did see one reference that said, somewhere between 1,000 and 2,000 micrograms, or 1 to 2 mgs. So as you can see, the SNAP recipients are quite a bit lower than the non-recipients and the rough estimate of the US intake. So why does this matter for inflammation and immunity? Well, low retinoic acid is linked to insulin resistance and fatty liver and coronary artery disease. I put some of the links here to the literature that you can take a look at later if you're interested. And from an immune perspective, vitamin A-related compounds support the immune functions that generate effective responses to viruses. So mucosal, innate, and adaptive immune functions. Specifically with magnesium, you can see again we have sex-specific dietary reference intakes. These are RDAs, 320 milligrams for females and 420 for males. And our SNAP recipients were way down at 210 milligrams per day, and non-recipients just a little higher at 248 milligrams per day. Both being a little bit below the already too low US intake estimate of 290. So from an inflammatory perspective, low serum magnesium is linked to all these inflammatory conditions: insulin resistance, type 2 diabetes, and non-alcoholic fatty liver disease. So from an immune perspective, magnesium is required for immune cell function. T cells and natural killer cells require it for proper function. And so again, we're seeing this pattern again where this nutrient is important, not just in terms of inflammation, but in terms of immune function. We're seeing sort of a similar pattern again with vitamin E. So our dietary reference intake, again, this is an RDA, 15, and SNAP recipients well below. 5.9 milligrams per day for the SNAP recipients and 7.7 for the non-recipients. Again, the non-recipients being close to the US intake estimate. So vitamin E has been controversial. Sufficient vitamin E over a long period of time appears to improve vascular function and prevents a cardiovascular disease. But short-term trials of vitamin E for as a supplement, supplement pill, don't appear to help prevent cardiovascular disease. So just something to keep in mind. In terms of immunity outcomes, chronic low intake of vitamin E basically increases the severity of RNA viral infections and even increases the risk of virulence increasing mutations in the virus. So it's kind of a double whammy. It's definitely needed for a proper host response to viral infection. Okay, and on to the last one, vitamin D. So as you can see, we have an RDA for a dietary reference intake, recommended daily allowance. It's 15 micrograms per day, and the SNAP recipients and non-recipients are both far below it. there was no statistically significant difference between the SNAP recipients and non-recipients, but anywhere around 3 micrograms per day compared to what the ideal or the goal of 15 micrograms. It's not even close. As you can see, the US intake estimate is also quite low, and so in general, we're not doing well as a country on vitamin D intake. So in terms of inflammation and immune outcomes, lower vitamin D status is linked to cardiovascular disease that's mediated by atherosclerosis or the hardening of arteries. It's linked to asthma and chronic kidney disease, and again, non-alcoholic fatty liver disease. All these inflammation related chronic diseases. Okay. In terms of immunity, higher vitamin D is protecting against acute respiratory tract infections, and actually may specifically help to prevent the pro-inflammatory cytokine storm that often precedes death in severe COVID-19. So may be particularly relevant in this day and age. Okay, so in short, basically, there's evidence that each of these nutrient deficiencies are playing a role in chronic inflammation and immune responses. Basically, the constellation of low fiber, beta-carotene, magnesium, vitamin E, and vitamin D all together may increase the risk of chronic disease and lower the immune competence of the people in our studied populations. So it's important to note, and just to remind everybody, I'm sure most of the audience is aware, we're seeing chronic disease and COVID-19 disparities in low-income minority communities. Low-income minority communities are having an excess burden of chronic disease and COVID-19. And these patterns we're observing might be driving in part the patterns we're observing in the nutrients might be in part driving the patterns we're seeing in the diseases. Okay, so that's sort of doom and gloom, but it's specifying exactly what's we think the problems are. And this is just to remind us all that we can address these things. So again, a lot of this comes from things I've learned from Abigail, but there's pretty simple foods that can address this. Almonds can provide fiber, vitamin E, and magnesium. Black beans, fiber and magnesium. Spinach can get us beta-carotene and vitamin E and fiber and magnesium. Spinach looks like it practically solves this problem by itself. Sweet potatoes, very high in beta-carotene and vitamin E. Vitamin D is a little trickier. I don't know if anyone else will want to chime in the chat at some point, but you can get vitamin D from eggs, and actually they are higher in pasture-raised eggs. There's a citation there if you're interested. Obviously, salmon and sardines also can get us vitamin D and vitamin E as well. So, okay, that's cool. These things could be changed. We could possibly help people in low-income urban settings by providing these foods. But obviously, anyone who studies food systems knows it's far more complicated than just knowing what we need to do. It's, can we do it? There's issues of availability. Who grows and who catches these foods, and who does or would sell these foods? What is the cost? How expensive are they? Cultural issues. Are there culturally accepted recipes that use these items? Cooking capacity. These are low-income urban neighborhoods. Does everybody have a kitchen? Habits, how malleable are people's food preferences? Are they going to be willing to try new things? So again, this is just to take a step back and look even a little, broader. Some of these things we're couching as nutrient deficiencies actually can be addressed by non-food interventions. So things like vitamin D. Vitamin D is obviously produced when you are getting exposed to a sufficient amount of sunshine. And, Possibly there are things like sunshine breaks during workday or built environment or green spaces that can increase sun exposure. These are things we can also consider in this context for improving vitamin D. So, you know, as we get closer to the end here, there's also non-nutrient variables that were associated with a high DII or a excess dietary inflammation. These were lower education level and lower effort to eat a fresh and healthy diet. So these two things are also theoretically modifiable. So, you know, if we see these patterns in other studies, we could consider interventions to increase general education, increase nutrition education, and increase the motivation to eat well. So these things might be worth testing. Okay, rounding this out, I think we need some context about what happens in the big picture. So, you know, if we were able to use this evidence to develop targeted incentives to improve the diets of SNAP recipients and lower their risk of inflammatory diseases, this might matter for fiscal reasons as well. Many Medicaid and Medicare recipients are on SNAP. You know, among US adults aged 35 to 80, 66% of those on Medicaid are also SNAP participants. So improving the diets of SNAP recipients might lower healthcare costs and lower overall government spending on safety net. So these are things to keep in mind. We obviously want to help these populations, but we want to keep in mind what's politically feasible and what can get proper momentum for political programmatic changes. So, you know, luckily we didn't invent this idea that food is necessary as a preventive medicine, or that food insecurity is driving chronic disease in America. This excellent op-ed in CNN goes through some of the details. You can click on that later on. We also didn't, you know, discover that bad diet equals chronic disease equals COVID-19 risk. That's been talked about many times, including in the New York Times. But we have further sort of characterized the problem and highlighted specific connections between inflammatory and immune dysfunctions in low-income urban neighborhoods. So basically, to sort of sum up everything I've said, because I feel like I've been talking too long, even though it's probably the right amount of time. Low-income minority communities experience excess burdens of chronic disease and COVID-19. We know this. I think what we see in this data is that these could be due in part to specific nutritional disparities. So we have a whole bunch of remaining scientific questions, and these might trigger more questions in you guys, but I think this will sort of move us into sort of the discussion section of the talk here. Do fruit and vegetable incentives lower DII scores? That's something that needs to be hashed out. Do these nutrient deficiencies associate with increased risk of chronic disease? We don't have a big enough data set to look at that in Food Nest directly. Do these nutrient deficiencies associate with increased risk of severe COVID-19? You know, what about the other non-dietary sources of inflammation? I mean, there's things like stress and poor sleep and pollution and toxicant exposures. How do these things interact with the dietary-driven inflammation? And so I think those are important science questions, but you know, we don't really need to wait around. Like, how can we improve diets now as we continue to learn? They could be fairly straightforward interventions. There's probably people on this call that have better ideas than I do about this. But you know, we sort of know what we would want to target in these neighborhoods. Fiber, beta-carotene, magnesium, vitamin E, and vitamin D. You know, the other thing to consider when you'd be thinking about these is, would these be for SNAP recipients only? What about store-level interventions, healthy minimum stocking standards? You know, are there other ways to fix these deficiencies? And just overall, should HHS, Health and Human Services, be talking to the USDA a little bit more frequently? So if you have chance later on, you can take a look at this brief 10-minute talk by Darius Muzaffarian. He touches on some of the bigger picture issues with these factors globally. But to sum it up, thank you to everybody here, people I mentioned and people I didn't even mention that have helped to make all this possible. And I'd love to take comments and questions.
Right. Tim, for your amazing presentation. We do have a few questions, and Abigail, I can unmute you because you've worked really hard with this project as well, and you might be able to provide some insight as well. So just let me know if you want me to unmute you. But we're going to go ahead and jump into the few questions that we have so far. So from our chat box, we have a question of how does HEI score correlate with DII scores of the study participants?
So that's a good question. We actually did look at that, and they are, as you would expect, inversely correlated. HEI, higher scores are better. DII, higher scores are worse. And so what you see is that the SNAP recipients do have lower HEIs and higher DIIs than non-recipients. That was a lot of alphabet soup, but thanks for that question.
Well, again, I said that in the Swetland Center, we like our acronyms, so it's just common for us to keep them going. All right. Another question that we had, so you talked a lot about vitamin and mineral deficiencies. Has there been any consideration of toxicity, specifically in regards to vitamin D? Is there ever such a thing that someone can have too much vitamin D, and kind of what are the issues quite associated with that?
So this is a good question, and it gets to a lot of the complexity in nutritional variables. I come from a environmental epidemiology background. Spent a lot of time looking at things that we primarily think just harm, but nutrients often, there's a sweet spot. You don't want too much, you don't want too little. And so this is a really good point. It also touches on the one thing I learned in med school about nutrition, which is ADEK. A, D, E, and K, fat-soluble vitamins, you can get too much. So we did not address that here, but it's a really good point. Any intervention that you would design or think about with vitamin D, in theory, you could run into problems by getting people too much. In some respects, that pushes me towards thinking a little bit about the sunshine related interventions for vitamin D. Having said that, that's obviously not without problems as well. I mean, skin cancer from excess UV light exposure does exist. So these are things that would need to be teased apart pretty carefully anytime you're dealing with these fat-soluble vitamins, and we're dealing with two of them here. Thank you for that question.
Absolutely. To add to that, with the idea of toxicity, usually coming from supplements. So you certainly have a gamut of vitamins and minerals when you walk into any drugstore that you go to, or really any gas station that you go to now with these small energy drinks. But this is quite possibly one of the reasons why there is the potential for vitamin D toxicity versus having the sun exposure or what is normal in your diet that might come from fortified foods. So I want to thank Abigail for that tidbit of information, and thank you for that question as well. We do have a question about getting agencies to talk more and kind of really integrate their work together. specifically Health and Human Services in the USDA. Can you talk about baby steps to make this happen within these two agencies or any other agencies that really need to kind of talk with each other about being able to address the complexities of what you presented on with our vitamin deficiencies, how that is affecting our lower income neighborhoods, as well as quite possibly just thinking about the ability to access, prepare, and having the willingness to try the items that you suggested, like almonds or spinach or anything like that.
So that's a tough question. I think, obviously I don't have a ton of expertise in the, regulatory policy world. Having said all that, these are two groups that need to be in the room together. And maybe one of the ways they can get in the room together is to see that they actually have the opportunity to have some synergy and help each other. If we're able to see things that the USDA can do to make spending less at HHS, we might actually wind up being able to lower the net, amount of government spending on safety net. But the key to all that, at least from somebody who's not in the policy world, is getting those groups in the room together, perhaps starting even regular meetings to have these discussions and work through where they can possibly reduce chronic disease to lower costs overall.
That getting the conversation apart sometimes, even if you are a dietitian, having a one-on-one conversation with a patient, it might be hard to kind of get someone to be able to share out information with you, especially with their 24-hour food recall. So we have a question about how did this study go about obtaining participants for the 24-hour food recall and improving the response rate?
That is a good question. I don't know the details of how recruitment was boosted. Perhaps Millie or Abigail or Wanda or Jackie, if they're on the call, will have more details, or Darcy. Nope.
Do they want to unmute themselves so that they can talk?
Oh, I forgot we're in a webinar, not a Zoom.
So Darcy.
Hi there. Hi, this is Darcy. Yeah, that's a great question. I think always this issue of participant engagement is key to issues of generalizability. So we recruited starting in 2015. And we used a community-based approach, which entailed a number of different strategies to recruit participants. So we had mailers, flyers, people coming to community events, phone calls. And once people joined the study, they then received regular communication from the team. So newsletters, reminder emails, or reminder texts. And then, as Tim mentioned, we had a fantastic data collection team that was consistent through almost the entirety of the study. And so many of our participants, once they were connected to their data collection person, Wanda or Jackie from the from University Hospitals Bionutrition Corps, and the CTSC, or the Clinical Translational Science Collaborative at Case Western, we were able to, they were able to maintain that contact. And so people actually wanted to talk to their survey data collector. So it was as Alicia mentions here, relentlessly calling people, keeping really good records if people change their address. And, you know, Tim gave you 3 years of data. We actually just finished up 5 years of data collection on this study, and we still maintain a very high response rate.
Thank you, Darcy, for popping in. I'm just going to check the chat one more time to see if we have any more questions. And it looks like we are all done for right now. But I think that this was an amazing presentation and very timely, considering how there is so much synergy between or interconnection between kind of the chronic disease that we're looking at, that we're kind of used to looking at with our lower resource populations or neighborhoods, and kind of having that kind of unfortunately married with COVID-19 right now. So I want to thank Tim again so much for your presentation and for the few questions that I did receive about being able to see this recording later and having access to the links that were provided in the presentation. I will have all of that available on the Swetland Center website at the end of this week. And for everyone who registered today, I do have your email address. So I will send out a notification letting you know that everything is up and ready to be viewed. So before we get ourselves, I guess, off of this call for today, I want to say that we have some amazing upcoming seminars for September through November. So again, it's going to be kind of the same process. Just making sure that with your completion of the attendance link, we can be able to record who was able to come today, but also who's kind of interested in the work that the Swetland Center is doing. So with that, I will use your email addresses to let you know about how to register and when to register for our upcoming seminars that are really going to talk a lot about pediatric health and kind of what does that look like from the environmental standpoint, as well as how COVID-19 has really impacted young children, especially those in our childcare and daycare setting. If you have any questions that you need to ask about the upcoming seminars, about any past seminars, please feel free to reach out to me, and I will be happy to help you get access to them, help you to register for them. But again, I want to thank you all for your time today, and we look forward to seeing you on September 22nd at 9 a.m. right back here in our virtual world of our Swetland Seminar Series. So thank you, everybody, and I hope that you all have an amazing Tuesday.